Finally, we're going to describe serendipitous findings. When doing axial imaging of the heart, it is very important to look at the structures surrounding the heart. We're going to show you pulmonary nodules, pulmonary masses, adenopathies, pathology of the chest wall, and this will finalize this presentation. In these three images, we can see minute nodules that were discovered on CT and not seen radiographically. Note that these nodules, one is at the periphery of the lung, another one is within the lung itself, and the third one is close to the pericardium. The three proved to be bronchial carcinomas. These two represent the lung masses. Both were bronchial cancers. One was to the left of the heart and the other one in the periphery of the right lung. This patient had an unsuspected bronchial carcinoma where one can see in the first image a large posterior mediastinal adenopathies. Note in the second image the presence of a bronchial carcinoma in the left paraspinal region. And the third image is of a pulmonary angiogram where one can see encasement of the proximal right pulmonary artery and also of the left, close to the left hilus, due to a extensive malignancy involving the mediastinal structures. In this patient, in addition to heavily calcified coronary arteries, one can see a triangular density behind the left hilus, close to the posterior chest wall, which represented a pneumonia. The adenopathies seen in this patient in the vicinity of the left perihilar region were due to sarcoidosis. Occasionally, adenopathies calcify, as noted here, in the vicinity of the right hilus. They may be confused with calcium within the arteries. This is a patient who had an anterior mediastinal mass with bilateral pleural effusions. There were also hilar adenopathies, and the diagnosis was of a lymphoma. This is a patient who had a lymphoma with adenopathies, particularly in the posterior mediastinum. The calcium screening study revealed the evidence of adenopathies that were not clinically suspected. These are three cases where one can see with lung windows the congestion of the dorsal aspect of the lungs. The first patient had dependent pulmonary edema and had heart failure. The second patient had similar findings, which were more prominent in the left lung dorsally. And the third are sequential images of a patient that had prominent markings in the dependent part of the lung with also incipient pulmonary edema. These are four pictures of a dear friend who had a negative chest rentgenogram, as seen in the frontal and in the lateral views of the chest. CT with the mediastinal and lung window showed a density to the right of the heart, which at these levels simply represents the top of the right dome of the diaphragm. There was no mass in this right lung. These are three pictures of a patient who had post-thoracotomy defects that simulated a Morgagni or an anterior diaphragmatic hernia. Note the density that is seen ventral and to the right of the ascending aorta in the mediastinal windows as well as in the lung windows. The defect that was noted simulated a mediastinal tumor. Diaphragmatic hernias can be readily detected when patients are screened for coronary calcification. In this first image, several cuts reveal a mass behind the heart, which simply represents a hiatal hernia. The presence of air within the mass makes this finding pathognomonic of being a hiatal hernia. In this second image, one can see calcification of the left anterior descending and diagonal branches of the left coronary artery. The patient had a large Morgagni hernia, which is noted ventral to the heart. The same pathology is seen in the lung window, where one can see the presence of air within the mass, and the last image shows the presence of abundance of fat. Occasionally the omentum herniates into the mediastinum. So the presence of fat and the presence of air in juxtacardiac masses are signs of a hernia. These are two cases with cancer of the left breast. The first one shows thickening of the skin, retraction of the nipple, and a retroareolar mass. This was not clinically suspected, although on re-examination of the patient, the mass became quite apparent. The second case showed a mass of the left breast, and in the last image, one can see of the same patient left axillary adenopathies. So we can then make the diagnosis of a unsuspected cancer of the breast on CT studies of the heart. This patient had chest pain in the midline, and the CT examination shows destruction of the sternum with a large retrosternal mass. A metastatic disease or a primary malignancy would be the first two considerations. This proved to be a chondrosarcoma with a mediastinal extension of the tumor. Dilated mammary arteries have to be differentiated from adenopathies. This patient had prominent internal mammary arteries. In individuals with coarctation of the aorta, the mammary arteries can be quite prominent, and this was a case that the patient had coarctation of the aorta and had prominent collateral circulation, particularly enlarged internal mammary arteries.